All right, let's get right into it. Today, we are breaking down airway management emergency medicine essentials, pulling from the fantastic foundational work by Dr. Abdulgnee Qutina. We're going to take what is notoriously one of the most high-stress, life-or-death situations you can face and transform it into a crystal-clear, step-by-step clinical workflow. If you want to really master the decision tree nature of emergency airway management, you are in the exact right place. Because emergency medicine is so reliant on algorithms, here's our roadmap. We'll follow the exact clinical escalation pathway, starting with assessment and clinical indications, moving to basic management, then rapid sequence intubation and verifying tube placement, and finally, the failed airway rescue and pediatric airway differences. Starting with Section 1, Assessment and Clinical Indications. 3 to 5 minutes. That ticking clock right there, that is your entire window. It's step 1 in the ABCDEs for a very good reason. Failing to secure a patent airway leads to brain hypoxia and death before you even have time to second-guess yourself. So, your very first decision point in this algorithm. Does the patient actually need intervention? You're looking for catastrophic failures here. Failure to protect, like losing that gag reflex. Failure to ventilate, so apnea. Failure to oxygenate despite giving them supplemental O2. Or maybe you're just anticipating a crash due to trauma or anaphylaxis. These are your definitive signs that the patient cannot maintain their airway and you absolutely must step in. Now, if you decide you have to intervene, you need to rapidly assess for a difficult airway. For anatomical barriers, rely on the lemon mnemonic. Look externally, evaluate the 3-3-2 rule, check the Mallampati score, look for obstructions, and assess neck mobility. But hey, anatomy isn't everything, right? You've got to watch out for physiological landmines too. Severe acidosis, hypoxemia, or shock. You absolutely have to optimize their physiology before you even think about reaching for a tube. Moving right along to Section 2, Basic Management and Adjuncts. Before we get fancy, we start with the basics. Choosing the right maneuver is key here. You'll generally use the head tilt chin lift for your medical patients and the jaw thrust for trauma patients to protect that cervical spine. But here's an interesting shift. The AHA 2025 update actually makes a pretty bold concession. If the jaw thrust fails in a trauma scenario, just use the head tilt anyway. An open airway always supersedes C-spine concerns. If they need ventilation, bag mask ventilation, BMV, is your absolute cornerstone. But your technique has to be flawless. This really needs to be a two-person, two-handed technique, delivering slow, controlled, 1-second breaths. If you rush this, you're just going to fill the stomach with air instead of the lungs, and that's a mess nobody wants. To help out with that BMV, we use airway adjuncts. An OPA is for your unconscious patients and strictly requires an absent gag reflex. Otherwise, they're going to vomit. The NPA is for semi-conscious patients who still have an intact gag reflex. But listen closely to this clinical warning. Never, ever use an NPA if you suspect a basilar skull fracture. You run the very real, very terrifying risk of placing that tube directly into the patient's brain cavity. Now, what if your initial assessment points to a foreign body obstruction? You transition seamlessly into this updated AHA 2025 cycle. For a responsive patient, you're doing 5 back blows, followed immediately by 5 abdominal thrusts, what we used to just call the Heimlich, and then you repeat. If the patient goes unresponsive, you drop the thrusts and immediately start CPR. Those chest compressions can actually provide the pressure needed to dislodge the object. Okay, Section 3, Rapid Sequence Intubation. When basic maneuvers just aren't cutting it, we escalate to our gold standard, RSI. This vertical checklist right here, the 7 Ps of RSI, is used in something like 85% of ED intubations. It's highly algorithmic. You prepare the team, you pre-oxygenate, pre-treat, paralyze and induce, pass the tube, and then immediately lock in your post-intubation and post-arrest care. Following this strictly minimizes the time that the airway is unprotected. Choosing your meds is a massive decision point in this workflow. You have to match the drug to the patient's specific physiology. Etomidate is fantastic for keeping hemodynamics stable. Ketamine is your go-to for asthma because it's a bronchodilator. Propofol is great for seizures, but watch out for that hypotension drop. Then you pair that sedative with a paralytic, like succinylcholine for a blistering 45-second onset, or rocuronium if you want a longer duration that you can fully reverse later with Segamedics. Section 4, Verifying Tube Placement. So, you've passed the tube. Great. But the algorithm doesn't stop. You now have to prove, mathematically and clinically, that you are in the trachea and not the esophagus. Do not guess here. Primary confirmation is literally mandatory. Visualizing that end-tidal CO2 capnography waveform is your absolute, indisputable proof of success. It is the hero of this entire step. Once you have that capnography waveform, you back it up with secondary anatomical checks. Listen for bilateral breath sounds. Make sure the epigastrium is quiet. Get a chest x-ray to check your depth. And remember the golden rule. If you are ever in doubt about where that tube went, pull it out and immediately reattempt ventilation. Which leads us to Section 5, the failed airway rescue. We've talked about the ideal scenario, but what happens when the algorithm breaks down? What if you hit the dreaded cannot intubate, cannot ventilate scenario? CICV. This is arguably the most terrifying situation in emergency medicine. When this happens, you need robotic, zero-hesitation adherence to your rescue pathway. The only thing that matters now is preventing hypoxic brain injury. Here is your exact decision-making process for the rescue. First, call for help loudly and immediately. Next, you drop the laryngoscopy and try a supraglottic rescue device, like an LMA or an iGel, just to get oxygen flowing without needing to enter the trachea. If that still fails, you immediately transition and prep for surgery. And this is it, the cricothyroid autonomy, your ultimate failsafe. It's all about knowing your anatomical landmarks. You identify the cricothyroid membrane right between the thyroid and cricoid cartilage. You make a vertical incision through the skin, then a horizontal incision through the membrane itself, and slip your tube in. Just keep in mind, this scalpel technique is for adults. If you're dealing with a pediatric patient, you're going to opt for a needle cricothyroidotomy instead. Speaking of which, Section 6, Pediatric Airway Differences. Kids are definitely not just small adults. Their airway anatomy forces you to fundamentally adjust your approach. They have a proportionately massive occiput that pushes their neck into flexion, a huge tongue, a funnel-shaped larynx that gets narrowest right at the cricoid, and a really floppy U-shaped epiglottis. Because of this totally different geometry, you have to use age-appropriate blades and uncuffed tubes for the younger kids, even though RSI is still the overall preferred method. Let's wrap this up with a quick take-home checklist to lock this in. By treating this as a rigid clinical workflow, you turn chaos into a manageable process. The airway is always priority 1. Assess anatomy and physiology thoroughly. Use RSI as your gold standard. Never start without a plan B and C for a failed airway. Always confirm with capnography, and reassess constantly. Which brings us to our final thought. You've now mastered the A in the ABCD cascade. But consider this. With the airway definitively secured and oxygenation restored, how will you immediately shift gears to optimize the patient's hemodynamics?
Thank you for watching this edition of the Emergency Medicine series. If you found this session valuable, please click the subscribe button below and turn on notifications to never miss an episode. Stay safe, keep learning, and I'll see you in the next lecture.